So we know the number one cancer in the throat now, past tobacco, oral pharyngeal cancer of the tonsils, base of the tongue, are from HPV.
Hi, this is Patrick.
And this is Laura.
And you're listening to This is Cancer.
Brought to you by Siteman Cancer Center at Barnes-Jewish Hospital and Washington University School of Medicine in St. Louis, national leaders in cancer. Patrick, I feel the need to apologize to you. I feel like I steamrolled through this entire podcast recording because I was locked in on our surgeon talking about head and neck related cancers.
Yeah, it was tough to get a question in there. I was trying to get in your peripheral every now and then and be like, I have a question.
Well, it's because in my 20s, mid to late 20s, which would have been in the 2000s, me and all my friends and people my age were starting to learn about HPV, and it was popping up all over, and we'd never heard about it before. Mm-hmm. And then, I had a abnormal pap smear, and they told me I had HPV, and I'm like, what does that even mean? But they told me at that time that 70% of people my age were carrying it. This is a sexually transmitted virus that is the leading cause of head and neck cancers.
Right. We learned a lot on this episode from Dr. Puram and from our patient guest. You had a little bit more of a base level knowledge of HPV and HPV positive cancers, but we learned a lot. And if you think that HPV positive cancers or HPV in general is something that won't touch you in your life, or that you've passed that stage where you'd be exposed to it, that's definitely not the case.
Yeah, we get into all of it, and I think this applies to so many people in our population, young and old, because kids can be getting vaccines. So if you're a parent, if you're in your 20s, if you're in your 60s, this podcast episode applies to you. Yeah,
a fascinating episode that I think anybody's going to enjoy. And these two guys were incredible and entertaining as well.
And take a listen. You'll be hearing mostly me.
Yeah, I'll pop up at a couple points.
Ron, you are a head and neck cancer survivor. And Dr. Sid Puram, you are I don't know what to say, that title that I already asked you with Siteman Cancer Center. Say it for me.
Otolaryngology. But you could just say, a chief of head and neck surgery or head and neck surgeon.
He's the chief of head and neck surgery, but it's otolaryngology.
Nope, gology.
Dang it. See, it's hard.
Otolaryngology. Otolaryngology.
You are quite the otolaryngologist, and we are thankful that you are here.
My pleasure.
And Ron is a practicing general dentist, correct?
That is correct.
Ron, I've never had a cavity in my life.
But there's more people like you, there'd be less people like me. So.
I know, but I just want you to know I've never had one.
Yeah, okay.
Never had one. Never had any dental surgery. Nothing. So we can carry on. Because this isn't about me. This is about you and a diagnosis you got less than 2 years ago when you found out that you had a tumor. Where was that in your head and neck area? It was
a year and 4 days ago. I got the diagnosis of a squamous cell carcinoma in my left base of my tongue, tonsil area, in my throat.
How did you notice it initially?
I noticed it because I had a lymph node on my left side, and the chain of lymph nodes along your neck called the cervical lymph nodes that I palpate all the time with my patients. And I noticed it was there for probably July of last year, which would be 2022. It was there for a little bit, and it's like it wasn't going away. It wasn't like a sore throat or something. And then I sought medical care. I had a friend of mine that's this general surgeon. He goes, I should probably have that looked at. And that's when I found out.
We know that HPV stands for the human papilloma virus.
Right.
And so when you told Ron that, was he like, what do you mean? How do I have him? He's been married for a long time and 3 kids. And how does I wouldn't know what to say if I found that in my throat. So how does that work?
I think this is a common thing that comes up. And I've had patients show up to my office who are 80 years old with this diagnosis, and their spouses are just sort of in shock. How did this happen? And in some ways, that's from a biology standpoint, the remarkable part about this is you can have an exposure to this virus most times 30 or 40 years before you get cancer, but sometimes 60, 70 years before you get diagnosed, depending on age of diagnosis.
It can be, dormant that long, I suppose, right?
Yeah, so the virus, the interesting thing about the virus is we were talking about this earlier, we think the virus infects many, many people. If you look at college students, it's in the range of 70 to 80%, depending on the study. But then if you look at people who are older in the 30 to 40 range, maybe even 50, 60, that number drops precipitously. And it depends on the study, but it probably ranges from 10 to 40%. And so interestingly, we think that the virus is cleared in the vast, vast majority of people. And obviously the percentage is high in college students. Why? Because college students generally have sexual activity. And so as part of that, they get exposed. But then again, the vast majority will clear it, and it's never a problem. And then there's this small group of people who the virus persists, as you said, lays dormant. And in a very small percentage of those people is able to then cause a cancer. And so the process where the virus is kind of laying dormant and may cause cancer is hugely variable. That could be 20 years, that could be 40 years, it could be 60 years. And the key thing is it arises in this group of people who, for whatever reason, we don't know why, but they don't clear the virus. And so it stays around.
So, Ron, you had the privilege of knowing a lot more and being educated about HPV-positive cancer because you're a dentist, so you knew more about it. But I would imagine that there are a lot of people that have been married a long time, they might be in their 40s, 50s, 60s, that would get a diagnosis like this and be, number one, very confused, number two, possibly embarrassed to even talk about that because they're very private. And it just has this, like, there's a sexual connotation behind it, you know?
To it.
And that surprises me that people still have that stigma out there, because everyone that's had any kind of intimate relationship, everyone, like they say, like 90+% of the population has it.
But I don't think most people know that.
And exactly, they don't.
Literally, that statistic alone in my mind is like, oh, okay, all right, I get it. That alone, that fact that 90% of people are going to come into contact with that.
It's so flipping common.
Yeah, flip a coin. You might have this.
But if you're 65 and you haven't been sexually active with anyone else except for your partner in 30 years, what could you say to people that didn't know anything about it or struggling with the diagnosis and, maybe embarrassed about even explaining to people what this is?
And what I would tell patients, I go, dude, almost everybody has it. Almost everybody has this, not a big deal.
And by you mean everybody has this, you mean everyone has been exposed.
Everyone's
mostly.
been exposed to it. And usually the cycle is is within 1 to 2 years after you've been exposed. It usually goes away. Okay, so we know the number one cancer in the throat now is past tobacco, is oral pharyngeal cancer of the tonsils, base of the tongue, is HPV. In men, 70% of the cancers in the throat are from HPV in men. Of the 21,000 new cases of throat cancer, it's going to be 15,000 a year, 70%. Mm-hmm. These are ballpark figures.
And that's mostly caused by HPV?
It is today. So 10 years ago, the HPV negatives would have been more common. But what we're seeing is this change in the seesaw and the kind of balance of these things. And now, based on some reports, we think HPV positive cancers are projected actually to be more common than HPV negative in the head and neck. And so that's a change as of, we'll wait to look at the data retrospectively, but it's probably true today in 2023. And it just happened.
So we're talking about oral sex, which would explain why it showed up in the back of the throat, right? So it's not just, it's not just sex with the downstairs parts, but it's all types of sex, right?
Yeah. And actually...
Did I just say the downstairs parts?
I mean, and actually from the perspective of head and neck cancer, it's almost exclusively oral sex, right? Because it's from an oral sex act, and if there's other types of things that are being done.
Right.
Because it can also live not just in the anus, but it can also live in the cervix. And the cervix is the most common place, but since it can live in the anus, there can be ways to get it that way too.
And for HPV, for me, like as a woman in my 40s, for the last 25 years, I've always been told you got to get your pap smear every year because that's one of the number one things we're looking for is to make sure that doesn't show up, because once it's cervical cancer is known as like the silent killer, right? If you're not getting your pap smears and you're not getting checked out. So when you said in women, the cervical cancer side of things is always what I think we hear most of. And we're not talking about head and neck cancers as brain tumors. We're talking about something totally different when we say head and neck cancers.
Right. Absolutely. Yes, you nailed that. So when I talk to my patients, they say, so head and neck surgery, what is that? I like to say it's everything above your collarbone, except for your spine, your eyes, and your brain. And that's pretty much what we treat. And basically a cancer anywhere else. It could be in the skin on the top of your head. It could be inside, your ear. It could be in your throat. Someone within ear, nose, and throat, and often a head and neck surgeon, depends exactly where it is, would be involved in that.
With HPV positive cancer, is there a point when you find it that it's too late? Because you say sometimes it's hard to feel the symptom.
Yeah, so the question of whether it's too late is I guess a relative question. So if the tumor spread to your lungs or elsewhere in your body, then it's too late to achieve a cure. And so that's the metastatic disease by definition in the head and neck is incurable. So those would be patients that we would say we're going to do whatever we can to treat this and extend your life and your quality of life. But then there's sort of the group of patients that have just ignored this for so long that they're no longer good candidates for surgery. And so then you basically have to put them down the chemoradiation route. And if it's early, because you can have a small tumor but just have it be in the perfectly wrong spot that you don't think surgery is a good idea. You can also have a gigantic tumor that you're like, in order for me to take this out, I would literally have to cut your entire tongue out and do all this stuff. And that's just not going to make sense. And those are the ones that get chemoradiation. And those patients don't do as well, right? I mean, they have a huge tumor with a huge lymph node. And so, of course, they're not going to do as well because you can't even perform a surgery to remove it. And you're really relying on the chemo and radiation to take care of it. But you have a huge tumor. What is a huge tumor? It's a huge ball of cells. So what's the chance that one of those cells is resistant? Well, it's a higher number than if it was a small tumor. And so these are the types of things we start to think about.
And so that leads me to the question that so many parents bring up, and there's been debate after debate after debate, was the first anti-cancer vaccine that's ever been created fights HPV, which prevents HPV-related cancers.
Right.
So what's the problem?
To be honest, I think it's a bit crazy that people wouldn't be more rabid about getting this. And I think it reflects a larger controversy in our society right now about vaccines and vaccine hesitancy,
Trust.
which has been magnified by everything with COVID. The things I would say that I tell all my patients when they say, well, now that I have this, is there anything I can do for my family? Yeah, there is. Number one thing is have your family, if they're age eligible, get the vaccine. And this is, I know that there's a lot of hesitancy about COVID because of how fast it was rolled out and things like that. This is not one of those. This is one of the ones where lots of testing, years and years of data from people with no evidence of any significant side effects or adverse events from the vaccine. So anyone who has sort of hesitancy about vaccines because they think these things are experimental, that's really not the case with this one. It's really been well tested, well tolerated, and well proven to be effective. And so I tell patients and even kind of researchers and other physicians when I talk about this that this thing is going to take off in the next few decades. And it's very likely that in the next 15 years, this may represent 70, maybe even 80% of all head and neck cancers.
Wow.
And if we're lucky and people actually get the vaccine, then towards the tail end of my career, this might go away entirely. And that's really a very cool thing to think about as a physician and as a scientist, that I'm treating this disease, and in the next 30 years, it's going to have a big impact on these patients. But by the end of my career, people will be like, we'll talk about it like that was some, old thing that, is no longer a problem in medicine, just like polio.
Get your kids vaccinated for this. It's huge. 11 to 12 years old is really the window. Get them. It's a 2-dose thing. Get them. All my daughters have had it. It's so important. It's so important to get them vaccinated for this here. And for women, of course, it's cervical cancer. That's a huge thing.
What was that first consultation like when you're finding out what stage you're at, what the treatment plan is like, with the survival rates, all that kind of stuff?
I think that when Ron came in, his case was pretty run-of-the-mill HPV positive case, right? He had a neck mass that was diagnostically positive for cancer. We had a sense from the scan that the tumor was in the back of his tongue. And so then we had the conversation about, well, there are two different broad types of head and neck cancer, HPV positive, HPV negative. You have HPV positive. That's an incredibly good thing. Your chance of beating the cancer is literally double right out the gate.
That's good to know.
And we talked about management. And something I remember telling you is you have two options, and both are equally good. One is chemo and radiation, and one is surgery and radiation. Both are equally good for your survival. But if we do surgery and radiation, we can really limit the radiation dose, which would probably limit the amount of side effects that you would have from going through all this.
So you chose to do the surgery and radiation.
Well, we knew it was going to be surgery, how extensive it was. And I didn't know they're going to do both sides of the neck, but I mean, that's just protocol. So yeah, we did that and did the lymph nodes and did the surgery, and then I was out for most of it.
But what was a surgery on both sides of the neck, the detail of it?
Well, the advantage of getting older is you get these little wrinkles in your neck. So I made the incision right along the creases, and then he took out the lymph nodes on both sides. I think 36.
All of them?
I don't know. It varies, but he took a lot.
36 lymph nodes?
Wasn't it?
I think it was even more. I think it was 30.
I'm going with 36 anyway.
I thought it was 36 on one and 40 on the other. But
Wait, how big are lymph nodes?
There's also like
tiny.
hot spots where they cluster more, like under the arm and in the neck. And
Actually, right.
Don't talk to me like I'm supposed to know that, cancer survivor. I don't.
just saying.
How would I know that? I've never met a bunch of lymph nodes before. I don't know how big they are.
I'm telling
yeah,
you.
you have lymph nodes throughout your neck, and depending on what you remove in the surgery, it can be 15, 20. The most I've ever removed on a patient is 212. And the thing about it is you have lymph nodes all through your neck. So even if you remove these lymph nodes, oftentimes there isn't a significant side effect. People worry about, are you going to have chronic infections and things like that without them?
Lymphedema.
The biggest thing is you have lymphedema. Exactly right. And so that's swelling kind of in the neck because the fluid that sort of sits around our cells isn't able to kind of move around and drain as easily. And so I like to tell patients that when you make that incision, it's almost like putting a dam in the middle of the neck. Mm-hmm. And then you give them radiation, and now the water's kind of muddy. It's mucked up in addition to having a dam there. And so you can get swelling in the necks, especially above the incision. And so we try to minimize the amount we have to do, and we decide whether to do one neck or both necks based on where the tumor is located. In Ron's case, it was in the back of his tongue. And so those tumors can spread to both sides of the neck. And so kind of a funny thing that might sound weird is we actually did the right side of the neck to prove to ourselves that it was clear, because just a scan is not good enough in 2023 to know that. So we removed lymph nodes with the hope that they were actually all clear. And that is what allowed us to really spare him radiation to that area, which was a huge, huge benefit to his recovery.
But I understand that you also had to do chemo.
Well, we kind of knew that was an option, and this may sound funny, but it was almost like a relief. I go, let's use all your tools. If we have to do chemo, let's do it. I mean, let's make it happen. I want this thing gone. So we did the chemo and the radiation, and
How soon after surgery did that begin?
4 weeks.
Okay. So you had to heal and
Correct. Mm-hmm.
go through all the drains and all that stuff.
Right.
Okay. And so then what was the chemo regimen compared to the radiation? How'd that work?
Well, we had it all done at Siteman in Shiloh, which is real close to my office. So on Mondays, I would go in there at 8 a.m. You get fluids first because the drug that they use for the chemo, cisplatin, did I say that?
Yeah.
And it's really hard on your kidneys. So they want to hydrate you with a liter of fluids first, and then you get the poison, the cisplatin, over a course of about an hour or so, and then you have another liter of fluids after that. So what I would do on my chemo days is they would start the fluids the first thing at 8 o'clock in the morning, and while I was getting the fluid and I had the IV in, I'd wheel over to the radiation, and I would get my radiation, and then I'd come back in, and they would switch out the bags and start the chemo, and then I would just sit for hours, whatever. Mm-hmm. And just hang out.
Did you do chemo every day in a row, or did you do?
Chemo was 1 day a week. It was on Mondays, and then I had radiation Monday through Friday. So.
But you did a couple weeks off after your first round of chemo, or a week off? Is that?
It was every Monday. I was supposed to be 6, but I was losing so much weight. Mm-hmm. They said, you're good. You don't have to do the 6th one. Like, oh darn, can I do one more, please?
Right.
It's funny you say that, but I remember the same way you were like, can we just use all your tools? When I was done with chemo, I remember going, can I just get in, just hit me one more time. Let's just really get it.
And that agreed. We were going to do that too. It was like, I told my wife, I go, I can do it. She goes, yeah, you're not. Because I was a sack of bones. It was crazy. And even the medical oncologist goes, yeah, you're done. Yeah, you've done 5. You're great. You're going to be fine. So First couple weeks I was fine, but probably after this, between the second and third chemo, the wheels started to fall off the cart. I was like getting really super tired, and then did not want to eat at all. I mean, I was just not. I didn't have the taste because of the radiation. I started to go away, so I lost a lot of my taste. And again, there was still some swelling from the surgery, so swallowing was a little bit of an issue. And then it got to be like, nothing tasted good. I didn't want to eat. I didn't want anything in my mouth. So it was everything I put in my mouth was all force fed.
It's work at that point.
It became work, and it's work that I did not want to do. So, I mean, it was just, we tried to press on, and I guess the impetus to get me back going was my wife, she actually sat there and goes, she started crying and goes, if you don't eat, you're going to die. I'm like, oh, okay. So, you put the boost, you drink the boost. It's got 530 calories per 6 ounces. Really good tasting stuff. Kind of, not really. But it's got all those calories, it's very caloric dense, and that's what I needed. It's funny because when we first started this, we're like we're going to have protein shakes, we're going to get all organic stuff. In the end, it's like anything I could get in my mouth.
Anything.
I don't care if it was ice cream. I don't care how fatty it was, anything,
Because you're wasting away.
I was losing like almost a pound a day.
Wow. Do you have side effects still from the radiation?
Yes. I don't know if it's from the radiation or from the chemo. Like tinnitus, my ears are ringing right now. Definitely, some foods burn still, like some of the red sauces, a glass of wine. That'll burn.
Burn your tongue or burn your throat?
Burn the side of the surgery. But after
Sensitive.
but after 3 or 4, you don't feel it anymore.
Yeah, exactly.
So good.
Yeah.
You found the same trick that I did.
It's funny how that works, isn't it?
Yeah.
But no, there are certain things that I don't eat. Super spicy foods. No jalapenos or anything like that. That would just smoke it back there. But I've gotten most of my taste back, which is huge.
I know we spent a lot of time talking about HPV-related head and neck cancers, but we normally think of heavy drinkers, well, that's going to affect your liver, and heavy smokers, your lungs. But can we talk just a little bit about the effect that heavy drinking and smoking can have on causing head and neck cancers?
Yeah, happy to talk about that. So when we talk about the smoking and drinking, ultimately these are, ultimately boil down to things that cause mutations, right? And the liver disease you mentioned is a little bit of an exception because the liver sort of processes different metabolites. So definitely you can get cancer from heavy drinking, but more often people get hepatitis and alcohol-related hepatitis. But when we talk about head and neck cancer, it's the smoking and alcohol that are causing this kind of constant set of mutations in the mouth. And eventually you get enough of those and all of a sudden you have a cancer. You probably don't get a cancer from a single mutation. In the vast, vast majority of cases, that's what we think happens. We think you need multiple mutations, multiple hits. It was just something that was sort of developed over the past 20 years as a hypothesis for cancer in general. And so these little hits that these cells are getting lead to changes in the cells that initially probably cause a precancer. That might go unnoticed. And then another hit causes the cancer, and then the cancer grows, and then maybe the cancer spreads. And so, as I like to tell patients, the smoking alcohol puts you at risk. Not everyone who smokes will get cancer. Not everyone who gets cancer will smoke. It's a complex thing. But certainly smoking puts you at risk. Smoking probably increases your risk of head and neck cancer by about 10-fold. Alcohol probably increases it 4-fold, and the two together increase it 40-fold. So they have a synergistic effect because both are now causing mutations in the mouth. And we see patients sometimes who their whole mouth is sort of filled with these precancers, and you do your best to take out the cancer and whatever you can around it. But we tell these patients to get you sort of totally cancer-free, we would have to literally remove your entire mouth, which isn't possible in 2023. So we're going to take out the high-risk areas and watch the low to medium-risk areas and hope for the best. But that's why the biggest risk for head and neck cancer is having head and neck cancer. What do I mean by that? Well, you were at risk the first time, so you're probably still at risk because of the behaviors you engaged in. HPV is an exception to that, obviously.
So can you talk a little bit about the importance of this new head and neck center at Siteman Cancer Center and what you're looking to do and hopefully change the game when it comes to treating head and neck cancer? Yeah,
I'm thrilled to talk about it. So the Head and Neck Tumor Center is I think, kind of unique concept. In the space of oncology, there are many different sort of cancer centers, right? Siteman Cancer Center, et cetera. And within those, there are often centers focused on specific tumors. The Brain Tumor Center is a great example of something where if you look at an average academic university in the United States, they all have brain tumor centers. And that, to some extent, makes sense. Brain tumors are devastating and a lot of research is needed in that area. But when you think about it, there's a lot of other cancers that are actually also scary and also need support. And so our enthusiasm for this, especially in the era of HPV, has been, how do we really make a comprehensive center at Siteman focused on head and neck? And that concept hasn't really existed nationally. There are a few kind of handful of other centers focused on head and neck, but they haven't viewed it in a very comprehensive way in terms of the patient experience. Our idea is that the center will provide this integrated experience. A patient literally calls a number, gets on the phone with someone in a very rapid way, and then gets set up with all their appointments, all their scans. They can be coming from rural Missouri. They can be coming from Arkansas. They can be coming from the East or West Coast as this builds out, or even internationally. And everything's kind of consolidated, and then they have a plan that takes into account all the opinions of the expert, and then that plan is executed forward. But for head and neck, it doesn't end there. Unfortunately for brain tumor patients, they often don't have a good outcome. That's just the reality of it. In head and neck, about 40 to 50% of our patients are still alive at 5 years, even with advanced cancers. So it's stage 4 head and neck. If there's one thing I could say, is not the same as stage 4 colon, breast, lung, et cetera. So many of our patients live. And so the other aspect of the center is, how do we actually help the people who are living through this disease? We don't just want them to survive. We want them to thrive. And so how do we do that? Well, we help them manage the fact that they don't have saliva. We help them figure out how they can swallow better. We help them with fibrosis of their neck. We help them with physical therapy. And you really can't do that if you don't have that integrated center approach. And the other flip of the coin is, how do we actually prevent people from getting cancer? And when they do, how do we treat them better so we actually have more survivors? So it's a research component. With patients' permission, we're hoping to sequence every tumor. It'll be a while before that leads to actionable therapies and changes. But you can't even begin to think about new ways of treating patients if you don't know what causes their disease. And so our idea is, if we can actually develop this sort of approach, we can start simple. Take 5 patients that had a remarkable response to treatment and 5 patients who you'd think would have done well but had a terrible response to treatment and may not have even lived 12 months, may not even made it to radiation before their tumor after surgery came back. And start comparing these patients, looking at the genes that are present, the mutations that are present, and try to learn something from that. Maybe just that simple spark, comparing a handful of patients, leads to the next study in the lab and the next clinical trial and changes the entire face of cancer. That's our vision. And I think part of the challenges we face are that for a long time, because head and neck has been relegated to a disease of smokers and drinkers, it hasn't been well studied. And so head and neck historically has always just sort of had this Me Too attitude to research. Oh, that worked in lung, let's try it. That worked in another site, let's try it. But that's a very sort of closed-minded way of approaching the research, right? We need to look at what's going on in these patients and learn from those patients, not just hope that they happen to have something that overlaps with another cancer. And so part of the work is to sort of make that easier for researchers. There isn't a lot of funding for head and neck. Head and neck is actually the least funded cancer if you look at the American Cancer Society by incidence, if you exclude rare tumors. So major cancers, if you divide the amount of money by the number of cases, it's dead last.
In my world, when I see something in the throat, I go, I'm not sure what it is. And if I don't feel comfortable biopsying it in my office, I'll send them to the otolaryngologist.
Otolaryngologist.
There you go. And then have them look at it. And I always tell patients, I go, you know what? This is what I think it might be. I don't really know, but I'm not comfortable with it. And I always tell them, let's get another set of eyes to look at it.
I'm glad you were paying attention to your symptoms and that you got directed to the right people. And thank you so much for joining us today, Dr. Puram and
really
Ron.
Appreciate it.
It's all good.
It's all good.
Thanks for listening to This is Cancer.
Brought to you by Siteman Cancer Center at Barnes Jewish Hospital and Washington University School of Medicine in St. Louis.
National leaders in cancer.
For more information on Siteman Cancer Center, go to siteman.wustl.edu and be sure to leave us a review and like and subscribe wherever you listen to podcasts.